Alrighty, Pharm Week 5 Antibacterials. Oh, that's pretty straightforward. So there's a difference between an antibiotic and an antimicrobial, which is why the term antibacterials and antimicrobials are used in this slide. Antibiotic, from a strict technical perspective or definition, is what's used by one microbe to harm or kill another. Um, Theorizing that that's why we are able to have the good bacteria in our gut, manage and control any populations of bad bacteria that might exist and populate in our gut, is through the use of their own chemicals that can be classified as antibiotics. Whereas an antimicrobial agent is something that we use synthetically, or not synthetically, but from a drug or medication perspective to try to control or suppress microbes of some kind. The book makes this a distinction, as do these slides. The book also mentions that in the hospital setting, these two terms are used interchangeably. So I don't know if maybe this is going to pop up on the NCLEX or what. I have no idea. When it comes to classifying antimicrobials, there are, according to the book, two different main classifications. We can classify it based on the organisms that are susceptible to that antimicrobial. For example, narrow spectrum or broad spectrum antibiotic. We can also go based off of a mechanism of action of said antibiotic. I don't have a clue what this is referencing. I couldn't find it in the book, so take that as you will. When it comes to those mechanisms of action, there are four main ones that at least this PowerPoint is going to be going over. There are a bunch of antimicrobial mechanisms of action, but supposedly these are the main ones. So we've got our cell wall synthesis inhibitors. These are going to weaken the cell wall and promote bacterial lysis, or I guess microbial lysis. I think these are generally talking about antibiotics. When it comes to weakening those cell walls, the reason why that works is because the inside of bacteria have such a strong osmotic force that if it were not for their cell wall, they would spontaneously rupture from a sudden influx of water being pulled in by that osmotic force. But they have a very strong cell wall. So if we go after that cell wall on the ones that are susceptible, then kaboom, they're dead. We also have protein synthesis inhibitors that can be either bacteriostatic or bactericidal. Bacteriostatic being that it's static, it's like stasis, not moving, being that it inhibits, it does not kill. Whereas bactericidal or bacteriocidal are going to actually kill the bacteria. And then folic acid is very critical for not microbes, I think it's actually just bacteria, for DNA synthesis. And we get this from our diet, whereas with microbes, they have to actually create it. So if we are inhibiting their folic acid synthesis, then they can't create DNA and they die. Awesome little explanation by Armando or something like that. Armando. Really great video to go back at and check on YouTube. So as we covered already, bacteriostatic stops from reproducing. They're static. They can't move, can't do anything beneficial. Bactericidal, they kill it. Drug resistance is something that's coming up and is always a major concern for us in the healthcare field. Oftentimes, microbes will become highly responsive at first and then become less susceptible and develop resistance over time with exposure. They can develop drug resistance, or they can resist the drugs themselves through a number of mechanisms. So I'm going to bounce back and forth here a little bit. So they can decrease the drug concentration at the site of action. So they can either cease the active drug intake or uptake. So we're going to be able to take advantage of some sort of a protein in the cell wall of a bacteria to allow certain antibiotics into the cell, because most of these antibiotics work from within the cell, not from outside the cell. And we utilize maybe some proteins in the cell wall to get the antibiotic inside. And I'm trying to think, I think it's, so decreased concentration, so they can do that in a couple different ways. Perhaps they can, I think the main one here is, for example, with an efflux pump. So the antibiotic is getting inside, maybe there's another protein similar to this one over here that the antibiotic is being used or is using to get into the cell, but then there are these activated efflux pumps, something, doesn't matter really what it is, something in the cell wall that pushes them out, and therefore they can't act on the bacteria. Maybe they will alter the structure of a drug target molecule, like the receptors inside of a cell. So we got these nice little circular guys here. Typically, there would be one of these receptor guys that would have a circular attachment point. I forgot the proper term for that. But instead, they changed the activation or attachment point to be a triangle, which a circle is not going to connect with well. So that makes it so that the antibiotic does not have as effective of an impact on the antibiotic or the bacteria. They may produce some sort of a chemical antagonist. So, where are you? Drug target. So maybe like creating a drug inactivating enzyme, like right here. So we have a chemical, an enzyme being made. That enzyme specifically works to destroy the antibiotic that comes in, or a part of it, making it so that the antibiotic can't be used to destroy the bacteria. I guess that works for both drug inactivation. I guess actually that's more drug inactivation, not chemical antagonist. I'm not seeing chemical antagonist. Maybe I'm just blind. Okay, whatever. You can imagine. So they create some sort of they synthesize something that antagonizes it. They get these traits, these abilities, among others, through a couple different mechanisms. One is through spontaneous mutation, which is just another fancy way of saying basically evolution. As the microbes go generation to generation, something funky happens with DNA, similar to what may happen with us or through any other species on the planet, and they develop some sort of a natural resistance to it. And over the span of time, as they are exposed to more and more antibiotics, this promotes that trait to become more and more prevalent and to evolve itself. And over the time frame of multiple generations, then suddenly they have resistance. This takes a lot longer to develop, as opposed to conjugation, which is this really unfortunate thing that bacteria have developed the ability to do, where basically they kind of like mating in some ways. And it's primarily with gram-negative bacteria. They pass on genetic material from one to the other through connecting, what are those things called? Like a little stick thing. Like these little doohickeys, kind of like a penis kind of coming out of both of them and they connect, I don't know. Just the first thing that comes to my mind. So that happens much more quickly as one bacteria develops resistance to an antibiotic, then it can pass it on to nearby bacteria at a very rapid rate compared to spontaneous mutation. And suddenly now you've got a whole bunch of bacteria that are resistant to what you thought was a perfect or a great antibiotic. So we can develop drug resistance based on practices of antibiotic use. So using antibiotics in a way that is not according to, I'm just making that way more complicated than it has to be. If we use antibiotics without continuing the entire dose period, like a 2-week period, whatever, and we say, we're fine, we're healthy, we don't need to have any more. Stopping it early is going to be much more likely to promote drug resistance over time. Using a broad spectrum antibiotic is going to be more likely to develop drug resistance because of the fact that you are taking this antibiotic and spreading it amongst exposure to a whole host of bacteria, and maybe the bacteria that you're trying to target and destroy are weaker, more sensitive to that bacteria, to that antibiotic, compared to this other group of bacteria that are hanging out to the side. And so you're not using enough antibiotic to destroy that bacteria, but you're using just enough to tell them, hey, you might want to be resistant to this. Or I guess really it's those that survived for a reason and they developed resistance. So the more often we use antibiotics, as opposed to trying to see if maybe the body can take care of itself, the more likely we are to develop bacterial resistance because they require frequent response or frequent exposure to that antibiotic to better develop some form of resistance. And then nosocomial infections, this is just going to be those infections that occur in the workplace, hospital setting, to patients, normally passed on from caregiver to patient, which means we are the ones responsible for high quality hand washing and cleaning up after patients and making sure that we're not passing things on. Also known as healthcare associated infections or hospital associated. I think it's hospital or healthcare, I can't remember. Yeah, so those are very difficult to treat, and they come from basically these really nasty bugs that get out in hospital settings that are exposed to all sorts of things and develop really high resistance. So super infections are basically what we've been talking about. Treat earlier if possible, and broad spectrum antibiotics will promote super infections. And ways that we can delay resistance is by getting people to get vaccinations, because by not getting infected by the thing in the first place helps to prevent the need for antibiotics. Get catheters out whenever we possibly can, because CAUTIs are catheter-associated urinary tract infections, are very high risks, and catheter use is very highly associated with catheter infections. Do our antimicrobial control, treat infections, not colonizations. So we may have colonization of a dangerous bacteria in our body, but if it's under control, then let the body sort of do its own thing for it, because at this point it's not caused a problem, and we don't want to introduce any more antibiotics than we have to. We want to try to use narrow spectrum antibiotics to isolate the pathogen or target the specific pathogen. We want to use disease experts, infectious disease experts, and local data when it comes to deciding which antibiotic to use for a tough infection. So someone comes into a hospital and they've got a serious infection going on, sepsis, we don't know what it is, but it's full-blown systemic. Before we do anything else, when it comes to antibiotics, we want to take a sample of whatever medium we need, whether that's blood, sputum, urine, whatever. We want to get those samples quickly and then start them on a broad spectrum antibiotic of some form to try to get this infection under control, because otherwise they might die. When we decide that we are going to go with some sort of a broad spectrum antibiotic, it's important that we use local data on infections in the community to determine what would be the most likely cause or etiology of this infection, and which antibiotic is most likely to be used or has been shown to be most successfully used with that infection, because that way we can have just the best opportunity to destroy whatever it is. Once those samples come back from the lab, then we can limit it to a more narrow spectrum targeted antibiotic. Antibiotic combos are great for specific purposes. They can be good for mixed infections or to prevent resistance, such as with TB, since a lot of TB has been shown to be very resistant. And starting off with multiple doses or multiple antibiotics can help prevent resistance by not giving those bacteria an opportunity to develop resistance. It can decrease the overall toxicity of each individual antibiotic because you might be able to use less of each. Enhanced bacterial. And we can also use it for times when we have really big superbugs. We have to have the antibiotic present at the site of infection for a sufficient length of time to be able to actually have it do anything. We do not want to use it just to treat some random fever with unknown origin because there are so many causes of fevers. We don't want to just throw antibiotics in there and suddenly now we have more of a promotion of drug resistance. We also really need to teach our patients about adherence because if they don't stick with their prescription for the entire length, they take the entire sequence of antibiotics, then they are at a higher risk of, one, not being cured. They may have it relapse, whatever that infection was, and then they are also much more likely to develop drug resistance. So when we are monitoring our patients, we want to monitor for clinical response in laboratories, so making sure that they aren't at risk for maybe bleeding out or having some sort of electrolyte or chemical imbalance, making sure they're not having any kind of an allergic reaction, measure the drug levels for toxicity, and then we also want to check and see on a regular basis, multiple times per day, how have they responded to the antibiotics? Have they had improvement, which we can detect based on a lowering of fever, other signs and symptoms that might show up, swelling perhaps, though I don't know how late in the game that would be showing up as a reduction in swelling. Better responses from the kidneys or from breathing, whatever it happens to be that's based on the symptoms associated with that infection. All right, so now actually on to the specific antibiotics. So when it comes to drugs that weaken the cell wall, we've got our penicillins, cephalosporins, carbapenems, and glycopeptides. Everything here, except for the glycopeptides, has what we call a beta-lactam ring, which is going to be just this kind of chemical ring that is, I don't know why it's called this, but it's a beta-lactam. So anything with this guy here, this nitrogen something or other square with an oxygen double, I don't know. I didn't do chemistry. This guy here, beta-lactam ring. So a lot of these are active against penicillins are going to be active against gram-positive and some gram-negative organisms. And they are pretty good. So we have several classes of them, or narrow spectrum classes, broad spectrum, and extended spectrum. The narrow spectrum, penicillinase, is a enzyme that is produced by bacteria that are used to destroy penicillin. Some of these narrow spectrum antibiotics, penicillins, are penicillinase sensitive, being that they will be destroyed by penicillinase that bacteria may produce, and some are resistant to penicillinase. Yeah. So, like I said earlier, bacteria have a very high internal osmotic pressure. So if we start poking holes in that cell wall, then we're going to allow water to rush in, fill up, and kind of equalize that osmotic force that differentiates the inside of the bacteria from the interstitial space. And then suddenly they rupture because they can't handle all of that extra fluid. So this is only going to be possible, though, to affect the bacteria during their growth and division cycle, which I think we should talk about, maybe not. So those are just specific points during a bacteria cell's growth. Lots of bacterial infections or bacteria have developed resistance in the way of beta-lactamases or penicillinase, another term for it, and they just make it so penicillin can't work. So we have to consider a different alternative. Specific penicillins that we are going to see, these are our narrow spectrum penicillins, so penicillin G, benzyl penicillin, or penicillin V, which is our oral formulation. I'm not sure if there is another term, there must be another term for it. G is given IV or IM, whereas penicillin V is given orally because penicillin G does not have the ability to cross the GI membrane. They are both bactericidal, and they are active against most gram-negative and some gram-positive. Luckily, these are the least toxic of all antibiotics, so they are a great first go-to when it comes to certain infections. Unfortunately, they are also the most common cause of drug allergy, but a lot of times penicillin does not cause a very significant infection. So the number one thing to do when we hear that they have a drug allergy to penicillins is to ask, what kind of a reaction do you have? Do you just get a little bit itchy and it's more of a mild inconvenience, or are you going straight towards anaphylactic reaction and shock? And then sometimes we can also get pain at the IM injection site. Yeah. We have some drug interactions to be considerate of. Aminoglycosides, another form of antibiotic, gentamicin being the main one here. This can be used in combination to effectively have the penicillins break the wall of the bacteria, and then gentamicin, the aminoglycoside, can get into the cell and affect the bacteria from inside of it. But while they have this great synergistic effect, we have to make sure that we administer it separately because penicillins in high concentrations can inactivate aminoglycosides. So what we're going to do is we're going to first pump in the penicillin. We're going to flush it through the drip that we have them on. And then we are going to, because once it's in there, it's going to be dilute enough with the body fluids that it's going to be safe to give gentamicin. So then we're going to pump in gentamicin, and they're going to have their wonderful synergistic effect. Probenecid, I don't remember what this is, but giving probenecid with penicillins can delay the renal excretion of penicillins, which can make them have a prolonged effect and can reach potentially toxic levels of penicillin. Ampicillin and amoxicillin, most people have probably seen or used amoxicillin. I think it's one of the most common ones to use with strep throat. Very common adverse effects, rash and diarrhea, though not quite so much with amoxicillin, since I think we have just simply a lower concentration by giving it via PO. It's not going straight into the system. Then we have our beta-lactamase resistant penicillins. The rest of these have been beta-lactamase sensitive, but nafcillin, oxacillin, and dicloxacillin are all very narrow spectrum. They're only used against Staph aureus and Staph epidermis, but they are beta-lactamase resistant, so we reserve them for those to fight them when otherwise other penicillins wouldn't be able to make much of a dent. These drugs do have the risk of developing MRSA, which is methicillin-resistant Staphylococcus aureus, which I think is what this is, just nasty stuff, poor kid. So we want to be careful when giving nafcillin, oxacillin, dicloxacillin that we need to be educating our patients on. Stick with this. I don't know if these are given IV only or if they're also given PO. If they're going home with it, you got to educate them on you need to take these appropriately. And yeah. Okay, so we also have our penicillin combinations where we combine a beta-lactamase sensitive with a beta-lactamase resistant or inhibitor to try to have that double whammy approach. Actually, it would be inhibitor, not resistant. Resistant would be these guys here, versus these ones. This way, those powerful penicillins, like ampicillin, amoxicillin, piperacillin, are able to be given and have an effect without having to worry about beta-lactamases, because our sulbactam or clavulanic acid or tazobactam are going to deactivate or inhibit beta-lactamase. Piperacillin, tazobactam, or Zosyn is a very common antibiotic that you'll see in the hospital setting. And something to be aware of is that any adverse effect that we see with these combinations is going to be due to the penicillin, since generally beta-lactamase inhibitors, these three folks here, there's very, very low risk of developing toxicity. All right, cephalosporins, these are going to be our most widely used group of antibiotics. They're similar to those penicillins in that we've got this beta-lactam ring. They are bactericidal, so they're going to kill the bacteria. We normally take them PO. They are broad spectrum and generally don't have much in the way of a toxicity. And something that I missed was that penicillins bind to a laundry list of different proteins that are collectively given the term penicillin binding proteins, and that's how they cause those are the ones in the cell wall. And those are the ones that by binding to them and causing ruptures in the cell wall allows for the cell wall to become weaker. So these do the same thing. They bind to those penicillin binding proteins and cause the cell to rupture by having that influx of water to equalize the osmotic pressure. And again, most active during growth and division, just like penicillins. Mechanism of action really just the exact same. And resistance, virtually the same thing. They have those beta-lactamases. These, in this case, can be classified as cephalosporinases. Third and fourth generations are going to be more resistant to cephalosporinases. And then there's also a fifth generation called ceftaroline, and is the only cephalosporin that's active against MRSA. So we might end up seeing more of that as time goes on. Some adverse effects of cephalosporins generally is going to be the most common is allergy, just some sort of a hypersensitivity reaction. Bleeding is a potential because ceftriaxone and cefotetin are going to reduce prothrombin effects or prothrombin levels by interfering with vitamin K metabolism. So if we have a patient who's taking ceftriaxone or cefotetin, then we want to be monitoring for prothrombin levels, and then educating our patients on, don't whack your arm on the side of the bed or something. If they're a fall risk, really be adamant about don't get out of bed without help. All that typical trauma resistant or trauma preventative stuff. And then there's also a risk of thrombophlebitis at the IV site, so we want to make sure that we are rotating that infusion site and giving it slowly and probably diluted too. We have a number of important drug interactions, again, such as with penicillins, because this is a beta-lactam ring medication. Probenecid can cause an interaction with cephalosporins in that it delays renal excretion, which can then prolong effects and or cause toxicity. With cefazolin and cefotetin, which are also, I believe, no, that's ceftriaxone. With cefazolin and cefotetin, there is they cause alcohol intolerance. I can't remember exactly what that promotes. I think it was some diflucan reaction, or it was this weird reaction that I don't remember ever being taught. And it's very, very, very dangerous. So we need to really, really encourage our patients never to have any alcohol while taking cefazolin or cefotetin. With our ceftriaxone and cefotetin, we want to be aware that any other drugs that we take those medications with that promote bleeding can have a potentiated effect, leading to an even higher risk of bleeding. Um, that might extend through all cephalosporins, but I think mostly it's ceftriaxone and cefatidine per the book. And then mixing calcium and ceftriaxone can cause fatal precipitates, which are what these guys here are. These little white stringy guys are the precipitates that form within this IV tubing and can cause clots and damage throughout the vascular system. So with our third generation cephalosporins, which I believe are the most common ones that we're going to see, which are used for gonorrhea, H. influenzae, salmonella, other stuff, which are what their preferred therapy for. They are highly active against gram-negatives, and they allow for CSF penetration. So that's why we're going to be using them specifically for things like meningitis, if it's coming from a enteric GI bacilli, per the book. Carbapenems. This is going to be imipenem. Again, same general idea of the other ones, cell wall synthesis. It is extremely broad spectrum, but it is not active against MRSA. It is low toxicity, but can lead to nausea, vomiting, diarrhea, and general allergy. Pretty straightforward. Glycopeptides, vancomycin. I believe this was the first one, the only one that is not a beta-lactam ring. Oh yeah, right there. No beta-lactam ring. And is the most used antibiotic in U.S. hospitals. But it's only active against gram-positive bacteria. So same idea here. Inhibits cell wall synthesis, leading to explosion, basically. But it does not do so by interacting with penicillin-binding proteins. Basically, instead, it just binds to molecules that serve as the precursors for cell wall synthesis. So they kind of inhibit the wall from forming in the first place or continuing to be reinforced. It also alters the cell membrane permeability of, and that's the same thing, inhibits RNA synthesis too. So we're going to be reserving this for only severe infections like MRSA, C. diff, and Staphylococcus. I wrote Staph. Staphylococcus epidermis. There is resistance in the way of VRE, vancomycin resistant. I just forgot the term. Xylobac, I don't remember. And Versa, vancomycin resistant Staphylococcus aureus. And we have some kind of unique adverse effects with vancomycin, and we'll notice some similarities with gentamicin. So we've got ototoxicity, which is going to be regarding the ears, nephrotoxicity, which has to do with the kidneys. Luckily, ototoxicity is rare and is usually reversible. So if we find out that our patient's becoming progressively more hard of hearing, then we know to maybe, hey, back off on the dose because they're starting to get some toxicity going on, and we can kind of subside or ease their anxiety by letting them know that this is normally transient. I don't know why they get red man syndrome. Was it here? No. So one thing about that nephrotoxicity is that we have to make sure that the dose is reduced for any patients who have pre-established renal impairment, because we can lead to potentially renal failure, and that risk is dose related and is also an increased risk if we are taking other nephrotoxic drugs like NSAIDs or aminoglycosides. Okay, so red man syndrome, this is kind of what this is going on here. This person looks very red, they're flushed, they may develop a rash, inflammation of the skin a little bit, tachycardia and hypotension. Thrombophlebitis is common. So what we're going to do is we're going to just dilute the solution and make sure we're changing the IV site as with anything else. And then, of course, anytime we give anything, it's potential for allergies. Now we're moving on to the bacteriostatic inhibitors of protein synthesis. Bacteriostatic being that it does not kill, it simply inhibits it. These are going to be our tetracyclines, our macrolides, and oxazolidinones. So doxycycline is going to be our tetracycline. It is broad spectrum and bacteriostatic. But there has been some increase in resistance over time. Because of that resistance, use has declined over time, but it's still kind of the drug of choice for rickettsial diseases like Rocky Mountain spotted fever, typhus fever, Q fever. I have no idea where you're going to catch those. Or infections caused by chlamydia, or cholera, or maybe acne or PUD, H. pylori. So a bunch of kind of strange diseases. So something to remember that's important about doxycycline and tetracyclines in general, they have this weird interaction with calcium. They like to bind to calcium, which is why we get this weird brown staining to teeth, especially common with children under 8. And because of that, you can also expect taking calcium will lead to a decrease in absorption. So remembering that can help you to lead to remember that there are plenty of other foods that can lead to a decrease in absorption. So we want to make sure that we are avoiding those when taking our dose. And then there are the adverse effects, some GI irritation, the funky looking bone and teeth stuff. And if we're given the tetracycline via IV, then we can develop some hepatic and renal toxicity. More likely, of course, if they already have pre-existing renal disease. They can develop some exaggerated sunburn because of photosensitivity. And then because it is a broad spectrum antibiotic, there is a risk of superinfection. Macrolide, azithromycin, or Zithromax is going to be a broad spectrum antibiotic that's bacteriostatic. And it's good against most gram-positive, some gram-negatives. Also has erythromycin as well. We're going to be using this if perhaps there's an allergy to penicillin. It's a drug of choice, though, for whooping cough or Bordetella pertussis, diphtheria, chlamydia, but we're going to be giving this in addition to a tetracycline. So we're going to use, like, actually, was that? I'm trying to remember now. Let's see here, get this out of the way. Pharm 2, I'm kind of curious. Reproductive. Oh, here we go. So chlamydia just says Zithromax. So you might have just Zithromax being used for chlamydia. You might have Zithromax and tetracyclines, which evidently was mentioned in the book. Yeah, it's also used for bacterial endocarditis. Anyway, so some drug interactions. It inhibits hepatic P450 metabolism. So it's going to increase the levels specifically of theophylline, carbamazepine, warfarin, so our blood thinner, warfarin, anti-seizure medication, carbamazepine, and then medication used sometimes for asthma and for COPD, theophylline. Luckily, though, it is generally considered to be one of our safest antibiotics, and most often it's just going to have some side effects like nausea, vomiting, diarrhea. There is a small risk of QT prolongation, which specifically here's our Q wave. This is an EKG, normal sinus rhythm here. We've got our P wave, QRS complex, and our T wave. And the distance between the start of the QRS complex and normally I would think it'd be the beginning of the T wave, but somewhere on the T wave, Basically, there's a prolonged period, meaning that the heart is not repolarizing fast enough, can lead to dysrhythmias, bradycardia, etc. And then, of course, there's always a risk of superinfection. Oxazolidinones, this is going to be linazolid or Zyvox. It's a newer class. It is bacteriostatic, as are all of these in this class, and is used primarily against VRE and MRSA. It is not active against gram-negative bacteria. This one's got some, or like an interesting adverse effect, myelosuppression. And it's based on how long we use it. Generally is considered reversible, but for however long they're on this medication, we're going to be wanting to do CBCs on a weekly basis, because with myelosuppression, we're talking about pancytopenia, which is going to be a reduction of pretty much all the different blood cells. Also has nausea, vomiting, diarrhea, hypertension due to some of the drug interactions, which we'll get to, and headache. So oxazolidinones or linazolid does have the potential of interacting poorly with SSRIs and MAOIs. So those are both being used by patients who have depression, anxiety. I think that's what MAOIs are. I can't remember. I think they're mostly not used these days as much unless you have like a more severe case, which is why I'm not as familiar with them. But with SSRIs, there's an increased risk of serotonin syndrome, since we actually have a slight weak MAOI action with linazolid, which is why hypertension's a potential concern. And when you mix SSRIs and MAOIs, there's an increased content of serotonin in the CNS neurons, basically implying that the SSRIs are going to work too well. So that can lead then to serotonin syndrome, which is just a nasty bugger, and you don't want to mess with that. So if they have to take oxazolidinones, maybe don't take SSRIs, or talk to the doctor about having a greatly reduced dose until linazolid is out of your system. There's also the potential of having a serious reaction with MAOIs, in that linazolid has that weak MAOI reaction or effect that's unintentional, and so mixing it with an already MAOI medication is going to increase that risk for a hypertensive crisis, and which is just simply what MAOIs have the potential of causing. Which means we also, if we have someone taking linazolid, we want to explain to them how it's important to avoid tyramine, which is an amino acid, which can be found in things like smoked meats, smoked cheeses, aged cheeses, like cheddar, beers on tap, since they can all promote a hypertensive crisis with anyone taking MAOIs or, like linazolid, an MAOI-like medication. Bactericidal inhibitors, this is going to be our aminoglycosides or gentamicin. It's not absorbed in the GI tract and does not enter the CSF. It is rapidly excreted by the kidneys, which means we're really only going to be giving it via IV, so only in the hospital. We're only using this for serious infections like E. coli, Klebsiella, I keep wanting to say kielbasa, and Serratia. Good way. This is a cheaper medication, which is really, really good given how often it's used, but resistance is also increasing with this common use, so that's bad. Similar to vancomycin, there is a risk of ototoxicity and nephrotoxicity. And with the ototoxicity with gentamicin, there is a potential of causing actual long-term damage from the use, because what happens is with the accumulation or higher low doses of gentamicin in the body, they tend to accumulate and deposit in the inner ear and damage the actual hair cells. Once those hair cells are damaged, there's no going back, they are done. There's of course also the potential for hypersensitivity reactions and blood dyscrasias such as neutropenia. So some of the things that we're going to want to do is we're going to really want to focus on monitoring their BUN creatinine to make sure they're not becoming nephrotoxic, checking their ears, the hearing, making sure that they're not having any autotoxic reactions, and the general allergic reaction response. So we have some beneficial interactions that we can promote, such as with penicillins, cephalosporins, vancomycin, to cause that double whammy of those ones open up the cell, the bacteria, and then gentamicin can go in and destroy the bacteria from within. And we also want to make sure we are not giving it, on the more adverse side, with any other auto or nephrotoxic medications. So no aspirins, because that can cause, or NSAIDs, because that can cause nephrotoxicity. Don't give it with vancomycin, which is interesting because it says here that we can potentially combine them, but each one can cause auto and nephrotoxicity as well, so I can't imagine they wouldn't cause a combined increased reaction. And then muscle relaxants can cause increased neuromuscular blockade, because gentamicin, or aminoglycosides in general, can inhibit neuromuscular transmission. So they can cause some flaccid paralysis, which is potentially fatal if it includes then respiratory depression. So we don't want to combine muscle relaxants and aminoglycosides. Inhibitors of folic acid. So we have our sulfonamides and trimethoprim. These are broad spectrum. They are very closely related in mechanism, in that they inhibit the synthesis of folate and folic acid. They are bacteriostatic, and as mentioned earlier, mammals don't synthesize folate. We get it from our diet, and bacteria have to rely on the creating of folate or folic acid. So if we block that, they die. Nope, sorry, they don't die, they just stop reproducing. Little fun tidbit here for you. The combo of these two is more powerful than each alone. They're used primarily for urinary tract infections, of which 90% of them are caused by E. coli, which these are like Bactrim. The combination here is really, really good to fight against. We have this medication will inhibit the hepatic metabolism of warfarin or phenytoin, which is another anticonvulsant. So they may bleed out or have a bunch of really nasty side effects, because both of those medications, warfarin and phenytoin, will end up accumulating inside the body. So some adverse effects: nausea, vomiting, some skin issues, fever. Stevens-Johnson is a big deal, and can cause death and some very severe reactions. Hemolytic and megaloblastic anemia. These sound a lot like side effects of phenytoin also, now that I'm looking at them. Hyperkalemia, kernicterus. So we do not want to give this to newborns or breastfeeding mothers. And with kernicterus, this is where we're going to have deposition of bilirubin in the brain. And bilirubin is neurotoxic and can cause nerve deficits and death. Normally it's bound to plasma proteins, but the sulfas can displace bilirubin from those proteins, at which point then the bilirubin is capable of traveling wherever it wants to in the body and crossing the poorly developed blood-brain barrier in infants. This is why we generally don't see kernicterus in older children or adults, because their blood-brain barrier is fully developed. Okay, here's all of that for you. Miscellaneous ones. So these are going to be our fluoroquinolones, metronidazole, and nitrofurantoins. Furantoin, I don't know how you pronounce it. I like toin. Rolls off my tongue better. So ciprofloxacin, Cipro, very common antibiotic. It's a broad spectrum, good with both gram-positive and gram-negative. Can be administered both orally or IV. And this will disrupt DNA replication and cell division by inhibiting DNA gyrase and topoisomerase. That's what it was. Topoisomerase 4. It's used for lots of different things. It is the drug of choice for anthrax. It can be used in the respiratory system, urinary tract, all of those places. I don't need to read it all for you. Has a unique side effect or adverse effect, tendon rupture of the Achilles tendon, specifically in kids and potentially those who are pregnant. I don't know why this is. I don't think the book mentioned it. I can't remember. But yeah, this is a very unique one. In the elderly, it can also cause some cognitive issues, so confusion, can cause them to become very, very sleepy, somnolence, can develop psychosis and visual disturbances, and we're going to avoid giving this to people who are young or pregnant since of that tendon rupture issue. They have a lot of absorption issues, so we're going to not take this alongside antacids or iron or sucralfate or calcium or any dairy products because we're going to have a decrease in absorption. It'll also increase the levels of warfarin and theophylline, so we are going to want to decrease the doses of those to prevent those from becoming toxic. We don't want them bleeding out or going and becoming, I think it's a hyper-metabolic issue with theophylline. Metronidazole or Flagyl inhibits DNA synthesis. It's bactericidal. This is mostly used for things like Giardia, bacterial vaginosis. It can also be used for H. pylori or C. diff, which it is the drug of choice, one of the drugs of choices for C. diff. And it only works for anaerobic organisms, so that's important to remember. We may use this as a prophylaxis during high-risk surgeries where anaerobes might have the potential of gaining foot. So colorectal surgery, abdominal surgery, or gynecologic surgeries are going to potentially disrupt anaerobic balance of microbes. So taking this prophylactically can help there. We have some seizures that can be rare as adverse effects, nausea, vomiting, diarrhea, all that. It's very important to make sure that you educate our patients on not taking alcohol within 3 days to 3 weeks, I think is what it was. Because this can have, I think it was similar in that there's a alcohol intolerance leading to, disulfiram reaction or something. No alcohol. Nitrofurantoin or macrobid, broad spectrum, and is different from the other antibiotics in that it is converted to a reactive form, specifically from the enzymes that only bacteria create. So it will remain unchanged, inactive, until it interacts with the bacteria that we're trying to get rid of, at which point it'll become active and destroy that bacteria. It is bacteriostatic at low concentrations and bactericidal at high concentrations, and is used almost exclusively for UTIs of the lower UT or urinary tract, not the upper urinary tract. We can have nausea, vomiting, diarrhea, anorexia, but we can decrease that with milk or taking it with meals. We can also develop some dyspnea as a hypersensitivity reaction. That normally will resolve, though, in 2 to 4 days after discontinuing the medication. They can also develop dizziness, fever, chills, and body aches. And then evidently, echinacea and cranberries may have some natural antibiotic properties, but I don't think we're ever going to give those in the hospital.